So end-stage glaucoma and what do we offer? How do we define advanced glaucoma is something that all of us have to remember. So it not necessarily is a 0.95 cup with just a thin rim or an advanced glaucoma with a central island of vision. But when you have central fixation involved or points close to fixation are involved, that also is advanced glaucoma. And of course, there are visual field criteria to say advanced glaucoma. We know that in India, we are not talking about early glaucomas, we are not talking about moderate glaucomas because most often the glaucomas don't present to us by themselves. We figure it out while doing a general evaluation, or they come to you when they are quite late. So most often the glaucomas present to us in an advanced stage, and what we see in the population is significantly underdetected. And what we also saw in several of the population-based studies that we did, close to about 50% of the glaucoma patients are blind, at least in one eye at presentation. So that is the group of patients that we are talking about. And it's not uncommon to see advanced glaucomas. So now when it comes to advanced glaucoma, there's always a controversy about should we treat them medically or surgically, how low is low IOP, and what is safe IOP level in these patients. So the concept of advanced glaucoma and wipeout came way back in 1957 when Sugar quoted this in a patient with simple glaucoma who sees with only one eye, who has a small central field of 15 degree or less. Medical treatment should be the only treatment. Why did he say so? Because at that point in time, whenever they treated somebody with an advanced glaucoma or only one seeing eye of a glaucoma patient, the chances of wipe out or loss of vision after a surgery was as high as 14%. And that is the reason why everybody was scared of doing a glaucoma surgery in an advanced glaucoma. In those days, mind you, it was a full thickness glaucoma surgery and the chances of hypotony were extremely high in those days. Advanced, the type of surgeries that we do today, where the optic nerve had damage because of anesthesia is taken care of. That means you do a periverbal anesthesia. You do not use adrenaline during anesthesia. You avoid pressure spikes either with anesthesia or during surgery. Prevent a hypotony in the intraoperatively as well as in the early postoperatively. Now, the risk of wipeout in an advanced glaucoma are as low as 0.95%. That means it's less than 1% of the advanced glaucoma patients that we operate. And what evidence do we have? Cochrane database again clearly showed that in early open-angle glaucoma, medical treatment is comparable to trabeculectomy. Trabeculectomy is associated with more local eye symptoms and higher incidence of cataract. This is not uncommon. We do see them. In more severe glaucoma, medical treatment was associated with more vision loss than surgery. So that is something that we all know. That is if it is inappropriately treated. So how do you choose treatment for a patient with advanced glaucoma? I would say look at several factors. The type of glaucoma, is it pseudoexfoliation, open angle, angle closure? What is it that you're dealing with? What is the level of intraocular pressure at which the patient started? Baseline intraocular pressure, what is the IOP control like now? Is there stability of the disease? Is there progression? Is the patient able to tolerate medications? Is the affordability good? And is the patient able to adhere to your medications? So there are some of my patients, just an example to give you that in a patient with advanced glaucoma who presented with advanced glaucoma bilaterally, a combination of medications that he is on with well-controlled intraocular pressure in the low teens over the past 8 years that I'm following up, he's been quite stable. So there is no need to worry that if somebody presents with advanced glaucoma, they are going to progress. But I think if everything else is taken care of and pressures are controlled well and patient is compliant, disease can be stable. On the other hand, you see somebody who progresses significantly and the patient has been non-compliant to medication. So of course, here you can't say, there's a risk of wipeout, so should I do surgery or not? We have to do the surgery. And once you do the surgery, generally the pressure stabilizes. You see the last few fields are stable. This is following a trabeculectomy. So you have to choose as to, whether trabeculectomy is necessary or medical treatment is working for your patient. Trab is definitely effective. But what we need to remember is that hypotony is something that we have to avoid intraoperatively and postoperatively. Make sure that on table complications, you do not have like suprachoroidal and choroidal detachment and things like that. So preoperative decrease in intraocular pressure, preoperative mannitol or preoperative dexmedetomidine, whatever is necessary to bring down the intraocular pressure preoperatively becomes very, very important. So they definitely play a huge role in managing these patients. So also when we have to do the surgery, what I generally do in very advanced glaucomas is that I do a surgery either under general anesthesia, which is rare, or under a topical and subtenon anesthesia with, of course, preoperative mannitol and preoperative decrease in intraocular pressure being a compulsion. Pre-placed sutures, slow decompression, tight flap closure, all of these are very, very important. So gradual decrease in intraocular pressure is something that one should aim for. Complications are something that we should definitely avoid. So I would say individualize based on how the patient's characteristics are and based on how the patient's eye behaves. So sometimes we may even end up adding oral carbonic anhydrase inhibitors if the patient is either unwilling for surgery, or if it is too high risk, if you think for the surgery, you don't want to do it, or the patient doesn't want it. Either ways, sometimes even an oral CII can be continued if the patient is able to tolerate and electrolytes levels are maintained. So refined surgical techniques, today we have the other procedures like MIGS and there's several other things that are available in the armamentarium, which we have to choose based on what is necessary for the patient. Visual rehabilitation, again, is very, very important. We have to make sure that we do everything possible to help them utilize their existing vision, improve the home environment, help with mobility training. All you have to do is tell them, approach magnification, or sometimes I tell our patients, sit closer to the window and try and increase either with the natural light or try and increase the lighting on your table, on whatever you're reading. That one small advice, I think, will go a long way in helping them improve their quality of life and use their existing vision. And of course, several of these patients just come to you once every 4 months or 3 months just to hear from you that, yes, you will be able to retain this vision provided you take care and use the medications regularly and follow up regularly. So they just need that reassurance, and we need to be compassionate to these patients who already deal with a lot of problem because of advanced glaucoma. So just to summarize, I think it's very important not to just talk about what we do, how we do, but I think it's important to individualize it, take care of not just the eye, but also their psychological status, as well as understand their social status and try to help them as much as possible to improve not just the vision, but their quality of life, as well as rehabilitate them as much as possible. Thank you so much for your attention.